Time we have here an sigmoid lesion with optical diagnosis is at least indicating superficial submucosal invasion.
Injection.
So we decide to go for ESD. It's also a small lesion, but it's in difficult sigmoid angle. So the scope manipulation is so difficult. So we are almost finishing the lesion. We count the area where is the invasion happening, and we just pass it now. So probably we'll finish the lesion soon.
Very difficult, very angulation, but we try to get best pathologic margin R0, because the aim of our procedure is to get embolic resection and to get R0 resection. So we obliged to change the position, and of course most of the procedure done by my brother Dr. Nawaf. I am just taking the part of the procedure. He did very well incision of the proximal margin, because our strategy from the start was to get rid from the most difficult part, injection. So we try to go with underwater.
It's around 2 centimeters in the sigmoid angle. So we made the proximal incision because it was the difficult part initially. Then now we are navigating the dissection as a regular one.
Stop. So we are doing the entire procedure underwater. The patient very obese, so we are changing the position to the right lateral. Injection. But the scope maneuverability very, very bad. So sometimes we have to push the knife too long, and this is very bad for bleeding and some sort of
water.
Actually, we started the procedure all, as I said, underwater or saline immersion and water pressure technique, because of the fibrosis and some angulation. The only hope is to go by underwater and water pressure technique and saline immersion technique. You can see I am suffering because the scope angulation very bad, and I want to get R0, so I have to dissect in SM3 just above the muscle, because the aim, you see, I did one plane and then I went again higher above it. So we are now dissecting the lesion completely. You can see this is the back side of the lesion, whether due to fibrosis or
yeah.
We use water please. Endocut I 222 and precise sec FF3 for the entire procedure, because we didn't face till now any severe bleeding, so the bleeding well controlled by freezing effect of precise sec, or for sometimes we use forced coagulation. So you can see we almost completed dissecting the lesion entirely. So we will we dissect the proximal side now safely, we hope. But we have some bleeding, and any bleeding during underwater pressure make the procedure difficult.
Yes. So usually we go with the optical. So the optical, it can predict the deep invasion in most of the cases, so we don't depend on other imaging. So your optical diagnosis should be able to predict how the depth.
Okay, thank you very much. We are in the final step of our procedure. This is the final cut of the lesion, which is very difficult, so we obliged to use IT knife nano for cutting isolated tip knife. I think you did a great job. This is
You
only,
did actually. I just get the last part of the lesion. Yeah, please.
We don't have any muscular defect, so no major bleeding. and this is the final cut off of the specimen. So, yes, you see this is only this small area left. So we are using IT nano because this is isolated tip, so not necessary to see the proximal end of the knife. It will be very safe. Only cut the left side of the lesion. And we suspect curative resection. I hope.
Inshallah.
So here, excellent job, mashallah, Nawaf, excellent job. But for someone who is not experienced, we are stuck in the middle of doing ESD. Don't do ESD. We are advised to reflect experience.
I think this is the beauty of endoscopy. So once you see such lesion, although small, it is better to refer to the tertiary center because there are some dedicated endoscopists who dedicated their life for doing such advanced procedure. This lesion, although small, it's a very risky lesion, and we suspect to be either intramucosal cancer and or SM1. The final cut is completed.
Good, Dr. Nawaf. Yeah, move now. Thank you.
Thank you. So you put the 2 clips in for the safety.
Small clips.
Can you take the sample out in order to check, inspect before you close?
Give me. No, give me our brother.
Section by section.
Will not come.
Small.
Yeah, not so big. Huh?
Well done. خلي أشوف.
Cancer. Hard.
Can you give me the specimen?
Can we get back to the floral room?
And
He will do it. I didn't do it. I did half incision. He did half incision and he did dissection.
He's
And
the
they take
boss.
the last piece.
I am his student.
That's what I always say. You must supervise.
Okay.
Nawaf?
I need-
Yes?
No? No tissue. Yes, please. So can